Locally advanced lung cancer. Lung cancer is the leading cause of the global cancer death, and reports suggest that up to half of the patients with non-small cell lung cancer will present with locally advanced stage 3 lung cancer. The complexity of the locally advanced lung cancer necessitates a thoughtful, individualized approach. The challenge of managing this group of patients includes determining the resectability in the surgical approach, patient fitness, and the use of the new adjuvant and adjuvant therapy. So, significant advancement in these years demands the comprehensive evaluation and treatment plan for multidisciplinary team. The preoperative staging consideration, the cross-sectional imaging facilities diagnosed, and the PET-CT is the most commonly used as it allows for the more accurate staging, and the special attention must always be paid to the adrenal gland, which are common site of metastasis. Additional imaging should be considered for tumors that appears to be invading local structures. The CT imaging is particularly useful in identifying bony or muscular involvement, and thoracic MRI may be helpful in patients with tumors abetting the spine, major vessels, or the brachial plexus to determine the invasion. All patients should have imaging and pathologic mediastinal staging when there is suspicion for mediastinal node involvement. The CT scan, MRI, and the PET-CT are all provided by the suitable view of the mediastinum. However, a negative PET-CT scan, unremarkable, appearing the lymph node on the CT and MRI, do not supplant the need for the pathological mediastinal staging in this subgroup of the patient. Furthermore, the suspicious node of the PET must be biopsied to confirm malignancy, as the inflammation, granulomatous disease, sarcoidosis can lead to false positive and overstaging of the patient. The endobronchial ultrasound and the transbronchial needle aspiration has largely replaced the mediastinoscopy and are the preferred method for mediastinal and the hilar node staging. EBUS provides reliable access to the station 2, 3, 4, 7, 10, and 11. Mediastinoscopy continues to be a valuable tool to evaluate the nodal levels at 2, 4, 7, allowing the analysis for the large tissue samples when the EBUS tBNA samples are inadequate, or when the clinical suspicion of the EBUS is negative or non-diagnostic. The aortopulmonary window and the para-aortic level 5 and 6 respectively are accessible by the left anterior parasternal approaches, that is the Chamberlain surgery, and sampling of these nodal stations may be carefully considered, particularly when dealing with the left upper lobe tumors and which have predilection for metastasis to the nodal level. Pathologic results of mediastinal staging help to determine the resectability and guide additional treatment and perhaps the most complicated clinical scenario. These differences are prognostic significant in a single station N2 disease and confers the better survival for multi-station or bulky N2 disease. Extrathoracic staging is important to rule out metastasis. Patients should undergo a PET-CT scan as well as the brain MRI for this purpose. If there is contraindication to MRI, contrast enhanced CT is also acceptable. The resection considerations, appropriate preoperative staging is essential in determining the resectability. This includes the MRI. T4 tumors have reported numerous times with reasonable outcomes. The resection of the T4 tumors considered if the nodes are negative for N1 involvement, and for the patient with T4 and 2, guidelines recommend non-surgical approach. Patient's fitness for a resection, the meticulous preoperative evaluation should be performed prior to recommendation in resection. And the treatments include the neoadjuvant treatment and the adjuvant treatment. The operative considerations including the approaches for the superior sulcus tumor or the pancreas tumor at the apex of the right upper lobe. Superior sulcus tumor may invade the structure into the thoracic inlet. Chest wall invasion resection must be carefully undertaken as both the lungs are mechanically ventilated to compromise. Spinal involvement. The lung cancer involving the spine may mandate the partial and complete vertebrectomy at the single or multiple levels to achieve pathologically negative margins. Diaphragmatic involvement. Invasion of the diaphragm is rare, occurring in less than 0.5% of the lungs, but portends a poor overall prognosis. Bronchial or cranial involvement. The tumor involving the mainstem bronchus or carina may be resected with acceptable mortality rates and a specialized center. Ipsilateral tumors of the same side or different lobe may be resected by lobectomy along with the primary tumor. Thank you.